Good. So Dr. Chilingirov will present the next.
I'm going to present the third case for today, maybe the last case. It's about 70-year-old male patient with high-grade stable angina, with typical risk factors, with atrial fibrillation. He has no known coronary artery disease. STEMI anterior 2013, treated with primary PCI of the LAD, the same year PCI of the right coronary artery, and redo procedures because of in-stent restenosis of the LAD in 2013 and 2023. The same year, dilatation of the left circ also was performed. The ECG is in sinus rhythm with no STT changes. The echo showed, let's say, preserved ejection fraction with anterior apical and mid-segment akinesia with no severe valve lesions. We did perform a dobutamine stress echo, which showed no viability in 3 apical segments and which induces ischemia in 3 inferior segments, but this is on low dosage of the dobutamine, as you can appreciate, 100 beats per minute. So we proceeded to diagnostic angio. You can appreciate the diffusely diseased, severely diseased posterolateral branch with, let's say, 3 severe stenosis. And we have the following anatomy of the left coronary artery. You can appreciate the distal left main disease with also disease of the ostium of the LAD and left circ. We also have in-stent restenosis of the LAD. We decided to do some imaging in order to check the left main. It's borderline 5.9 square millimeter. We have ostium of the LAD 5.4 square millimeter, and we decided to do also some physiology in order to decide if we have to treat it. And we did FFR, which is 0.65. This is the case. So, if any comments are welcomed.
Just comment regarding. Obviously, there is the LAD is large and goes over the apex, so it covers a partly of inferior wall and could be contributing to the results from dobutamine stress test. The point here is that it is difficult to assess independently significance of left main stenosis with this distal LAD stenosis, and if we want to properly assess the contribution of left main stenosis to the global FFR, we should first dilate the LAD lesion and then to reassess the significance of the left main. The right coronary is undoubtedly the posterolateral branch should be treated. There is a critical stenosis in the distal third. And the third comment for me is regarding IVUS, because in this case I would be very curious about the anatomy of this in-stent restenosis. I mean, is it some in-stent proliferation only, endothelial proliferation, if there is calcification? This is new intimal neurovascularization of the stent, because this could influence the strategy, because some neurovascularization in the stent is really resistant to all types of our interventional treatment. The patient could receive another stent, because I see there is a lot of calcium. I don't know how the IVUS looks like, but it is very important for me, not only the area, but the morphology of this in-stent restenosis. This is extremely important in those cases. just to know how to go, because this could be a good case for the DCB on the posterolateral branch and mid-cap Lima to LAD, and that could resolve everything.
Okay. I'm pretty sure that they're working right now in the cat lab, so we can connect to them.
Давайте да промиваме лидокаин, правете 50.
Валери?
Чиста вода. Да.
Ние те виждаме.
So I just presented the case, Dr. Gelev. We had some discussion.
So, what the discussion was,
Interesting.
I'm pretty sure, yes.
So,
So, what we have done up to now, we have a 7 French access. We put it wires in circuit in LED, and we did IVUS, starting from the circ, because we are not sure about the ostium of the circ, and the circ is IVUS is more than 4 millimeters, definitely. There is a small instant restenosis, which is 3.9 as far as I remember. And the ostium of the circ is it's more than 4 millimeters, square millimeters. So we went, we made an IVUS from AOD, and the left main from the circ, distal left main from the circ is 9. We went from AOD, and we could not pass this lesion, what you can see here, instant lesion at the second, I think, diagonal. But proximal AOD is around 5. You can see, or 4, you can see the measurements. And
no, we don't see.
Left main.
Can we see the IVUS?
And the left main is
Може ли да включите камерата към IVUS?
around 6 millimeters. So what we did, we made a dilation of this lesion with 2.5 and 3/0 balloon up to 20 atmospheres, and you can see we achieved some result, but
Може ли да пуснете IVUS в
not
движение?
optimal. I cannot hear you. So this is the dilation with 2.5 high pressure. You can see this bunch of calcium on the top. This is...
Valery, please, can we slow down just to see the IVUS first, just because this
This is the IVUS from
interesting...
LED.
Yes, this is LED stent, and there is a arc of calcium just behind the stent, which is
36.
same. Okay, so there are a lot of calcium
A lot of
nodules.
calcification. Still, there is not this around 180 degrees. We are coming to the proximal part, 180. So this was measurement. It was above, definitely above, around 5. And this measurement, the lowest measurement is 4.2, as far as I remember. This is the left main, and the circ, and this measurement is 5.9,
Okay.
and this is the left main.
Okay. Good. Okay. So let's see the angio, and then I see that
This is the inflation
Dr.
of
Stoyanov is
3/0.
impatient to make a comments about that.
Yes.
We have around 50 minutes. We can comment a lot of things, but my concern is about the indication for this treatment, because the indication was 3 segments in inferior wall, proved by echo, and now we are treating mid-LAD in non-viable
Yes.
territory.
Yes, exactly. But after that, probably you've missed. We have a functional assessment. I was with the same measures and FFR 065
FAD.
of AOD.
Here the point is, as I already mentioned that LED is very long, goes across the apex and goes like a posterolateral branch, inferior wall. If you look carefully, and this is probably the reason that there is a tissue, there are vessels there, and this in total makes the FFR significant. I personally would treat first the LAD restenosis and then reassess the FFR.
That is what we are doing at the moment, and this is the FFR distally. You can see after the treatment of the restenosis, which we did with TRIO, more than 22 atmospheres. Probably it could be done better. And now we are going to do, we did calculate DPR, which is around, it is 83. But now we are going to make papaverine. Промивка ми дайте и направете още 20 лидокаин. We are going to use to make papaverine, and after that we are going to make a pullback and see what pattern. Чисто още много. Тези са чисти.
Всичките са чисти. Махнали сме всички.
Супер.
Just notice the green curve on the screen. Can we see the FFR screen? Because it is. Can you switch to be on the bigger screen? На големия екран да сложите това нещо. Да ги смените. Това, което е малкото, да стане на големия екран. Okay.
We are making the papaverine. Готови ли сме за след малко за запис?
And
Запис.
exactly, this is the change of the shape of the curve, which is
Не е
very,
лошо да гледам и аз.
very important. And it is 0.77, 76. Probably it will be even lower.
So I'm making a pullback, and we are going to see whether we have some change.
Okay.
And what is the pattern of the pullback curve?
80.
The shape of this curve is extremely important, the clue about the significance.
86, 94, 91, 93, 95, 1.
So maybe you should work more on the stents.
Yeah, let's. Unfortunately, можем ли да го преместим?
Може да го ползвам.
It is 0.76, but according to our feeling here, because the curve is, it's recording only the FFR, there is a diffuse disease. I mean, in the stent, it is 0.80. After that, it goes in the mid portion 0.82, 0.90, 0.96, and approximately 1. So it has the feeling, you see, имаме ли криване? So you can follow, почни от началото. You can follow the curve, не, тук би било, ти да отгоре.
Може и с пръстче върху екрана и да го действаш, така.
Точно така. Дай го от началото.
Така.
You can see the curve up, and you can see that there is absolutely, this is the vasodilation, and you can see that it is a flat one. At least for me, there is no big step up. I don't know, what do you think?
Definitely, here is a point, just 5 complexes to the left, where the curve starts to go closer. And I don't know, however, without looking simultaneously on the pullback and on the angio, and here where is the place where here is exactly the place when the curve starts to
Because
closer.
there is a step up distally to the curve, distally to the vessel. You can see, I mean, distally to the stent into the vessel. It's, I don't know how to say, it's very diffuse. We can work a little bit more on this instant restenosis, and probably we are going to do one more measurement. But in my opinion, and in my view, definitely this is not a big lesion, because if it was a very significant lesion, it was going to be positive on the stress test. And we have such a pattern of diffuse curve, and we have a FFR, which is, of course, it is positive 0.77, but not that much positive. So there are two options, and okay, give some ideas, even.
I think that still the stent is underexpanded at the area of the overlap, and should be a little bit opened a little at the level of the stenosis.
From the panel,
We are talking about the indication. Actually, what is the patient complaints?
not much.
Okay, and what was the ejection fraction of the patient? 52. Okay, without, and there is no, yes, it was not viable, but the so-called not viable could be not visible segments on echo, because there are some segments, especially on the apex, which are not visible on echo sometimes. And there are some thinning of the myocardium somewhere.
Patient had anterior MI in the past, and he was treated with primary PCI. So we have from the echo apical akinesia with, I cannot remember with or without thinning, but there is no viability in these segments, 3 apical segments.
There was no change in the kinetics
Yes.
after giving
The low dose.
the dose of dobutamine.
Yes.
This is what
And to clear
we
the
have,
question,
just to be correct in the, because you know, it is very easy to state this statement, but visibility is something very tricky to be proven, and if you compare 3 or 4 methods different, you will could obtain very disappointing results because of disagreement
in fact,
between methods.
the echo team
And there is
quite
one more
experienced.
comment, Dobry. Just to remind you, the FFR distally was 0.65.
Yes, this
before.
is what I'm talking about. That actually,
Technically-
this FFR means that there is a vascular,
Viability.
there is a vascular tree there. If there is no viable myocardium, together with the viable myocardium, disappears also the vessels, and this positive FFR at the beginning definitely proves necessity to do something, because complaints sometimes are also uninterpretable. There are patients which are limiting themselves. They don't have complaints because they sit at home or go just to the shop 10 meters from the place they are living, and okay, they know they haven't symptoms, but they are.
So the question
Anyway.
here, Dobry, the question here is this. We have improvement in FFR around 10, even more points. It's around 77, around 0.80. The idea is, do we think that if we go technically more demanding, putting more higher pressure, putting even a shock wave, and if we improve this lesion, whether we are going to achieve an FFR much more different from what we have now?
I don't
And
know.
can we reach this
Nobody
thresh
can
point?
answer. No, until you do all these things, nobody can answer what will be the effect
Yes,
of
but
this.
what I'm saying, we have a pattern of diffuse disease and some improvement. And I'm not sure we can, whatever we do, we can make much more in this direction. And we have a lot of data concerning the PPG in publications that it is not changing a lot, and in the same time it is increasing the peri-procedural complications.
Here,
Of course, unfortunately, they are not changing much the clinical situation in these patients.
the problem
in these
is,
patients.
sorry for interruption, Valery, but the problem is that FFR less than 0.67, if we look at the trials, goes into the hard endpoint change in the
Exactly.
disease
I
course
do-
of the patient.
I
Less
do
than
agree.
0.67, there is increase in myocardial infarction, there is increase in death. So
But-
with the 65 on the,
Yes, but now we have 0.77.
yes, but initial FFR was 65, so the starting point is from there. And if you leave 77 FFR, this is a very poor result from angioplasty. If you want to increase and to improve the result, you have to achieve at least FFR 0.85 or better 0.88, according to data to improve the
Yes,
patient
but this is,
the real
not always possible. That's what I'm saying. That means that in a diffuse disease, you cannot achieve this threshold of FFR.
then
And
send the
even,
patient to surgery for mammaria.
This is a viable option, which is not proven yet. Two. And what we know is that especially in the last publication on this topic, especially that's why we choose this something which is diffusely diseased. So we can go aggressively, we can go even stand the left main, but we are going to be much less than the FFR, which we want to 0.90. Unfortunately, these patients, they do not have any improvement in the clinical situation, but they increase, in fact. And only less than one quarter of them, very aggressively treating them, they achieve this FFR, which is our threshold.
Yes,
Or better.
this is a big point of concern in these cases, because if you guide your PCI based on FFR data, the problem is that in such a diffuse disease, 40 to 60% of the cases are impossible to reach the thresholds which are, let's say, as I said, 0.85. This is at least should be as a target value, and
Okay, we can-
more than 88, 0.88 it's better. More than 90 is excellent. But in this case, I'm really doubtful that you can achieve that. Here it
Okay.
is even
We can push a
more
little bit
because
more
of
with
the
balloons.
disease of the side branches. This patient has 2 or 3 diagonal branches which are severely diseased, which means that the situation is even worse than you measure.
We'll do some more efforts, and after that we'll decide what to do. We are going to inflate a little bit more. I'll take a balloon, which is a shorter one. I'll put some drug on it.
Why
and
not
after that
scoring
we are
balloon, high pressure scoring balloon, trio, if you have?
Yes, but too much talking and the wires get stuck. If we have to go, I will go directly for a shock wave. because coring balloon, I'm not sure, because there is a calcium and an
Outside.
expanded stent and the calcium behind the stent. So if we have to treat something, this is this calcium, which is outside the stent, which is not accessible with other devices. So we are going to put a shock wave here and see how things are going to change. But I will go only, my idea is to treat only this lesion and see how it will improve the FFR, because from all other data that we have still the patient has a myocardial infarction and he has a minimum lumen area more than 4 in the other segments, and I'm not sure that it will change anything if we go and treat this aggressively. So we are going to put a shock wave, 3,
Okay, so now
because for me this is the only option that we see
LED, good.
to address this, this calcium, which is in the unexpanded stents. What do you think?
So good, probably yes, the best solution.
Excellent solution. Yeah.
If it's available, probably this is the best solution.
We have the lytics balloon too, but it is not advisable to use it in instant.
Now there is a change during the last months that they changed the statement that probably only on the freshly placed stents it is not.
That's what they claim. This, I mean, the guys from.
And the same was from Abbott with
Yes.
AVO at the beginning. So
Yes, that was the same. It is still actual because they have concerns about the coverage of the.
it is the same with lytics. So tomorrow I will show you the case with lytics with instant restenosis. Which was terrifying. So this is now shockwave.
Колко време имаме от
Я го изводим.
хипер...
What is the antiplatelet therapy of the patient?
Да ти бъде честно.
Nikki?
Dual, for sure. Dual antiplatelet. Yeah, I don't know if it's on ticagrelor or clopidogrel. I don't know. Yes, you're right. My question to the cath lab is, which size is the balloon?
3.0.
3.0.
Clopidogrel and aspirin.
Clopidogrel and aspirin, and but he's on triple therapy or just double without anticoagulant, or we don't understand.
No, for sure,
indication
triple
for
therapy.
anticoagulation.
No, for sure.
The patient
triple
don't
because
have atrial fibrillation, or
So
he has atrial fibrillation, but right now he's in sinus rhythm.
Okay,
I'm pretty
this
sure
is-
that the therapy is
he's
triple.
triple, okay, so.
oops. Okay, it crosses. They predilated with trio balloon, so there is a visible stent under expansion, probably because the distal stent also. It is my visual impression that probably the distal stent is larger than the middle stent in the LED.
You can see it easily with clear stent or stent vis, clear stent. I don't know what kind of technique is available.
Clear stent will show. Ако искате да
But
направим.
anyway, it is visible. So you're preparing the IVL balloon. How many pulses usually you start on?
Depends.
In this case, what you intend to do? How you plan to manage this? Yes, that here Nikki gives an idea that probably if you make a stent vis before before IVL and after inflation would be good for demonstrating
There is, you can see it clearly now. We can do the stand this.
I'm not sure that they're going to see.
We are looking from the monitor, which is not your monitor. Okay. So we will not see the stand this
We are
anyway.
going to show it with the camera. Let's focus on the treatment.
Yes.
And
Okay. Той няма да излезе на този монитор.
Okay, let's proceed with IVL.
okay, David Chetri. 4 atmospheres.
Четири.
David.
Дайте power therapy. Шест.
6. Айде пък. Малко да му дадем.
How many pulses you applied?
10. 10.
One
4
therapist.
4 atmospheres. 10 pulses. Some.
Графия да видя, че се поотвори някак.
This is.
There is some improvement, you see. Okay?
David.
Four.
David.
Another 10.
Unfortunately, we don't have a clear solutions for these calcium
Yes.
nodules, even when they are behind stent struts, and even when they are behind overlapping stents there. But
Maybe
we
a
are
little
going
bit
to-
further. To,
It should be just in the middle of the emitters, and then the waves are more powerful. The most powerful energy is delivered if the lesion is in the middle of the bone. Now we put. The issue with the shock wave is when you inflate it once, it's very difficult to.
отварям.
Да. To at least with these balloons, the new ones are not that because it becomes very bulky and very difficult to. Yes.
Maybe now there is some improvement visible.
Of course, we
Yes.
cannot see the result. We have to put a balloon again, a Nancy balloon. Да, пак.
Maybe 3, 5.
Do you plan to stent this segment after shockwave therapy?
No.
No.
No. If it's not necessary because we have a caged vessel, there is a proliferation in this caged vessel, and if you put another stent, it will reduce the woman even further.
Yes, they will do DCB. They will use DCB.
Дай още една. Дайте ми един балон 3 на 12.
OPN.
No, NC. Finally, we are using shockwave. Probably it will work. Yes.
Добре. Ние нямаме ли тройка инсимена?
Ще вземем един по-къс. We will take a shorter one.
Okay.
Ще ми фане ли тук?
So, in total, you made 5.
5 therapies.
5 therapies.
15
Five.
plus.
50 pulses. Okay.
50, yes.
And now you will take
An NC balloon.
3O to 12 NC balloon to dilate this segment. Okay. There was some disease also in the proximal segment of this stent, but maybe there you use just a NC balloon. Am I right?
But this is more than 4 millimeters, the whole vessel from there, because the IVUS did not pass through this lesion. Everything above this vessel proximally is 4 square millimeters, at least, in a patients with previous MI in this zone. So I think we have let's say in my view, that's an evidence that we have a good woman there.
Maybe a little bit further, just
Yes, no, that the balloon has slept.
and very slow inflation, just not to rush.
No, it is.
Because it will slip again
Yeah.
if you inflate it
I'll
too
pull it
quick.
a little bit further. I'm trying to keep it in the middle of the balloon.
Yeah, but slow inflation is the key in those cases. Very slow. 2 atmospheres, wait until the balloon opens, one more, and when you achieve 8 to 10, then you can be more faster in the inflation, but
Cool.
Some nice,
patient.
I think.
These are 20
22.
atmospheres, but you can see the
20
calcium is
how-
rails.
Maybe if you go up to 30 will be good.
24, 26.
26. This is like during RIT interventions, but in Sofia. Because I'm a fan of a little bit high pressure, dilatation is starting for me from 20 atmospheres up. Of course, you have to have a good stand grafts on the shelf,
Let's
just in
make
case.
here.
Yeah.
Mhm. Хайде пък, че имаше време. So, maybe a little bit better, but
I still think that 3O is a smaller balloon for this.
Yes, maybe it would be good just to make another measurement on IVUS, just to check for sure, taking into account the calcium shadows around the vessel. The 3O balloon is really small for this vessel, but there is another statement that the best
Let's
is
do
the
it
biggest
afar.
enemy of the better.
and here the enemy is perforation. Okay, let me
Even rupture.
let's do an FFR and see what we have achieved. Huh?
Take into account that this is a very diffusely diseased vessel, and another option is just to take 2 very long drug-coated balloons just to cover whole
No, we
this.
are going to do drug-coated balloons, but
Yes, and
at
to
the
check
end.
the results after 1 month, because sometimes because of the cytostatic effect of
we shall see. Дайте
DCB,
промиваме тук.
the result is
Чиста вода.
unexpectedly good. I don't know, Nikki, what do you think about that?
We are using
Давай.
in whole our instant restenosis lesions, DCBs, and if we can achieve good results, I don't follow up my patients regularly, on a regular basis, if they don't have complaints. But if you have such an experience, that will be nice to share.
Давайте да промиваме.
Yes, just
Чиста
because
промивка.
sometimes the result is not amazing after the PCI, but if you follow your patient after 2-3 months,
Мисля, че
you
да,
can see
защото
that
има много
actually it improves later on. Just because this is my hypothesis
Биогрижи
that
се там за лидокаин.
because of the drug and this cytostatic
Това е
effect,
чисто, нали?
Да.
Чисто.
even
Да,
cytotoxic,
махнала съм хепарини.
to be more precise.
This is really good concept in native vessels, but in stent restenosis, okay, because we can not perform really good differentiation in between neoatherosclerosis and proliferation. Probably that's the point.
Yes, this is what I'm talking about
Готови
from
сме?
some cases, not in every case.
Зайчева насам да виждаме.
Valery, what was the DPR?
We just made a
There
FFR.
are many extracystoles and the DPR is
Добре, не ни лъжите.
What is this, 77?
077.
As far as 76. But with this extracystoles, it is not correct.
yeah.
Just it is 77,
Stop.
76.
Стоп и го пусни пак. Now we will see without extra beats. 078.
Yes, you achieve amazing improvement of
Amazing
one,
result
of
for the
one
resources.
unit improvement.
Let's see, and we are going to
I
just
think
tell me the FFR, what is the here,
85.
85,
and here is where
here is just above the stent. You can see it
make
on the
a picture.
on the furrow. Here is here, the next
No,
one is here.
Can we see the floor?
can we see the angio?
Колко е тук?
91. Натисни просто педала.
Аз съм го записал, бе, моля ви. Добре, де, ето.
97.
And? DPR колко?
97 is no.
97, so you have some pressure drift.
So,
Yeah. Затегни.
Okay, so if we add the 3
No.
units up to your 77, you have 080. So this is just for the improvement of self-esteem after all this labor. And I'm still thinking that probably a good exercise test just to see the physical capacity of the patient.
now we are going to do it. We are going to do
and
it.
the
but,
regular exercise test, and then
But
to
firstly,
No,
to
we are
decide
going
what
to
to
do,
do. And if the patient
we
is
are going to
symptomatic,
do a stress echo with exercise, and we are going to decide from this on. So we are going to put a DCB here, and I think we will finish the procedure because in my mind we have exhausted our resources, what we can do.
and the
what
next
the
time
panel
maybe
thinks.
you should start with posterolateral branch because we a little bit leave it alone, but there is a critical stenosis on this PL, and I think that the treatment with the
but this,
DCB
this branch is a size of 2,
yes,
and it is not inferobasal hypokinesis. It's maybe lateral, clearly lateral, but we do not have this lateral ischemia on the stress echo. And this side branches,
How many kilograms is this patient? And how tall is he?
has 90 kilos and is 185 maybe.
Just because of
He's
the...
a big guy,
Yes.
but his vessels are not so distally.
So, the treatment now is DCB.
Maybe DCB on the posterolateral for the future, yeah.
Yes.
There is no options for stenting this kind of.
No, I think that in these vessels less than 275, placing stents nowadays is not a very good idea.
Yeah.
Despite what
Damage.
Juan said that we should not, maybe we should stent these vessels, but I personally have a big hesitation to stent vessels less than 275, to be
So
honest.
we inflate the 30
This is my
by 30
personal opinion.
GPC, yeah.
So for how long you keep the balloon open?
We can keep it here for 1 hour.
For 1 hour is good if the patient survive this.
The patient is asymptomatic, so.
So that
Ако
could
сега
keep...
усетите си, да ни кажете.
We have 30 seconds.
Okay, so you keep it for 1 minute
I couldn't.
or 2?
No, just these are 40 seconds. I think that's enough. We have some data that even the second inflation is not delivering much more drag X, but this is in it's in vitro. But anyway, we can do it one more inflation.
What type of balloon is that?
Protégé.
Ah, okay. But
You see, there
yes,
is not
the
a
opening,
big
yes.
indentation here on this vessel finally.
Yes, exactly.
No big waste. That means that what we have achieved is achievable for the whole vessel and it is valid for it. We don't have a clear, let's say, a dog bone view.
Can we see some another projection,
Сега добре ли?
undulation?
Или малко има стягане? Okay.
It's even better.
And he has complaints.
Do you intend to inflate the balloon proximally or another
think-
balloon for proximal treatment? See, you're not very enthusiastic.
No, you are absolutely right. Let me take the balloon out. Is there a rationale for this?
I mean that usually my practice is for instant restenosis to cover, when I treat some segment of the stent, I prefer to treat with drug the whole stent, not only the
But we
tightest
don't
part.
have an instant on IVUS, we don't have a restenosis. Do we have a tissue over there? I mean,
yes, there was.
proliferation.
There was. You can see your record afterwards carefully.
There was in the circle. Има ли нещо там? Let's see the IVUS and we are going to decide.
Преместете да вижда. Диде.
So this is the stent. I barely can see because it is just proximal to the lesion. It is less than 0.5 of millimeters. The greens are 1 millimeter.
There is some eccentric tissue. It's up to you.
We don't see it. We are very close here to this image. This is the
Yes.
this is the vessel, the native vessel.
Which has
It's up to you.
360. Yeah.
Okay, we'll take your advice. Дайте една тройка още, 3 на 20.
Maybe 3.5, Valery?
Моля?
По-дълго
Да.
да спрем сега.
3.5 to 20?
You are more and more demanding.
As always.
Uh, 320.
I agree with you. 3.5 is the size.
Yes, it is very strange that with Dr. Želeva we are almost always on the have the same opinion.
It's 325.
Overlapping opinions, yes.
There is a compromise, 325 by 20. And
Those born in January are very, very persistent guys.
that is how we survive.
Okay, so 325 to 20, what type of DCB is that?
Protege,
Protege.
but this is the NC option.
Okay, let's see the dilation and then we will proceed with the silver sponsor symposium.
You can proceed, and if something interesting happens, we are going to inform you. I mean, if we are out of time. So this is a procedure which is not very convincing, but we have and we have a lot of these patients, unfortunately. I mean, these are no exceptions, but that's what we have.
You cannot, okay.
Oh, the guiding is not.
Maybe a little bit further. No, back.
A little bit back.
Back.
Yeah, I can see it, but.
But it's very difficult
not
in this
reacting.
calcium.
No, it's here.
Maybe a
Okay,
little,
so
yeah,
it's going
this-
back.
I think that it's
Correct. Awesome.
okay.
We have overlap of these bones, so
Still
10.
10.
That's fine.
Може ли да пуснете следващата презентация да сме готови?
Таймер може.
Timer.